The present video presents a case of a patient with increased femoral anteversion. X-rays are usually evaluated before clinical examination of the patient. These are the X-rays of an adolescent patient. Note in the right image the prominent lesser trochanter and increased valgus, both suggestive of increased femoral anteversion. Next, clinical evaluation is performed, with the patient standing and in prone and supine position. Note the increased internal rotation in the middle image, which is in the prone position. In this particular patient, a hip scope was planned followed by a proximal femoral derotational osteotomy due to increased femoral anteversion. The preoperative planification is shown. Note how the osteotomy site is marked and a 4.5 locking compression plate is planned to fix the osteotomy. The following images show how the patient is positioned preoperatively. Note the use of a postless hip distractor. The following video shows the hip scope of the patient, in which a labral tear was confirmed. The labrum was repaired using 2.8 knotless anchors and a 1.8 anchor for the anterior labrum. The following sequence shows the planned derotational osteotomy. From left to right, 2K wires are placed to control femoral rotation. Next, the osteotomy is performed with an oscillating saw. The distal femur is rotated externally to correct the increased femoral anteversion, and the last two images show the osteotomy fixed with a 4.5 locking compression plate. These are the final fluoroscopic images of the proximal femoral osteotomy. Note the adequate fixation and reduction and the restoration of the femoral version. This is the postoperative radiographic control 3 months after the procedure of the same patient. Note the advanced consolidation at the osteotomy site. All patients start postoperative rehabilitation 6 to 12 hours after surgical procedure. A continuous passive motion device is set from 0 to 60 degrees of hip flexion. This is used to prevent fibrosis in the anterior capsule. A hip brace may be added if deemed necessary, with a lock range of motion from 0 to 60 degrees. All patients use crutches with no weight bearing allowed for 6 to 8 weeks. From 6 to 8 weeks, all patients complete their full range of motion and start weight bearing when the osteotomy is radiographically consolidated. From 8 to 12 weeks, patients progressively increase strength and start jogging. From 12 to 16 weeks, all patients start personalized training.